हेलो एवरीवन। हाय, नमस्कार, आदाब, सत श्री अकाल। कैसे हैं आप लोग? तो वेलकम अगेन to yet another session of Unacademy, and we are going to discuss another topic, another important topic for today, which will be renin angiotensin and aldosterone system and much more about your blood pressure. So before we begin, I would like to take this opportunity and we would like to discuss a few things about Unacademy. So as you know, I am Dr. Paramjeet. I am a physician, a cardiologist, a YouTuber, and from last 4 years, I've been simplifying medical concepts on YouTube. And there are many free tests going on about NEET PG on Unacademy. So आप वहाँ जाके इसका benefit ले सकते हैं. इसे भी unlock करना free test है. You can just write my code here, Paramjeet, and you will be able to apply for this test. You will be able to go for these tests on these dates. Make sure that you do. तो इन डेट्स पे आप जा सकते हैं, फ्री ऑफ कॉस्ट टेस्ट दे सकते हैं. रिमेंबर करिएगा, ध्यान रखिए. और इन सारे डेट्स पे जरूर 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 टाइमिंग याद रख लीजिए. 21, 22, 23, 24, 25, 26, 27 ये तारीख को डेट है. फ्री ऑफ कॉस्ट यू कैन गिव अ टेस्ट. एंड तो द टेस्ट हियर, ये टेस्ट सीरीज जो है आपके लिए फ्री है. सो मिस नहीं करना है. प्लीज मेक श्योर कि इसको आप शेयर करें. इसका लिंक आपको नीचे मिल जाएगा. ओके. एंड रिमेंबर, ऑल इंडिया का एक बड़ा मॉक टेस्ट भी होने वाला है, विच इज गोइंग टू बी ऑन 27th at 9 AM. यहाँ पर भी आप हमारा कोड यूज करके बिल्कुल जाके बिल्कुल अपने तरफ से फ्री ऑफ कॉस्ट एंट्री ले सकते हैं. और क्या चाहिए बताओ? फ्री ऑफ कॉस्ट आपको टेस्ट करने को मिल रहे हैं, फ्री ऑफ कॉस्ट आपको क्लासेस मिल रही हैं. तो ऑल, इफ यू लाइक, देन यू कैन ज्वाइन द प्लस सब्सक्रिप्शन. प्लस सब्सक्रिप्शन में रिकॉर्डेड क्लासेस मिलेंगी बार बार. आप क्लासेस, जो अच्छी क्लासेस आपको अच्छा लगता है, इस क्लास में अच्छा पढ़ा है, उसे बार बार पढ़ सकते हो. और कई सारे टॉप एजुकेटर्स हैं, क्विजेज हैं लाइव, और जो रिकॉर्डेड क्विजेज हैं, और साथ में बहुत सारे क्वेश्चन बैंक्स भी हैं. सो दीज आर द ऑप्शंस. एंड आइकॉनिक सब्सक्रिप्शन में यू गेट द सब्सक्रिप्शन ऑफ प्रेप लैडर अलॉन्ग विद दिस. तो हमारे कई सारे लोगों ने FMGE में टॉप किया है. दिस इज ऑल्सो वेरी गुड. तो आप भी कर सकते हैं. और स्पेशल क्लास आज शाम को भी मेरी होगी 5 PM पे. ये सबसे ज़रूरी अटेंड करना है आपने. इसमें हम हार्ट के बारे में, हार्ट फेलियर के बारे में आज डिस्कस करेंगे. 5 PM स्पेशल क्लास. नीचे अनअकैडमी के लिंक पे जाके आप मुझे फॉलो करिए. यू कैन फॉलो मी फॉर फ्री. देयर इज नो फीस टू अटेंड स्पेशल क्लासेस, इंटरेक्ट विथ मी, आस्क क्वेश्चंस. तो this is also an marathon batch for 2 months, which you can join if you are interested. And these are so many new batches coming up for you guys if you want to prepare, right? 2 महीने की short classes, बहुत सारे doctors, बहुत सारे लोग, and a lot of variations in subscriptions if you want. 2 महीने के subscriptions हैं, simple light subscriptions हैं, सस्ते subscriptions हैं. So you can choose. And if you want to try free of cost, then हमारा कोड है ही, है ना? So you can give my code and you will be आपको एंट्री फ्री मिलेगी. ये एक और है 16th का, तो ये तो हो चुका है. ओके, सॉरी. What about this? This is the code which you can use to get 10 to 20%. 10% तो होगा ही, बाकी 20% तक भी डिस्काउंट मिल सकता है. So now let's go about the heart. Heart के बारे में we will be talking about the blood pressure and how RAS, the system which manages the blood pressure. We have already talked about ECG. We have already talked about a lot of different types of ECG in the last classes. तो ये सारी ECGs के बारे में हमने समझाया है आपको. अगर आप, if you want to understand that, you can just attend the last few classes which I have done on Unacademy here itself. So please do attend that. और we will be talking about blood pressure. हमने ब्लड प्रेशर में बैरो रिसेप्टर मैकेनिज्म समझा था, कीमो रिसेप्टर मैकेनिज्म समझा था, एंड वी अंडरस्टूड द सेंट्रल रिसेप्टर मैकेनिज्म, वी अंडरस्टूड द, ये सब हो चुका है. ऑटो रेगुलेशन हम देख चुके हैं, ऑटोनॉमिक सिस्टम कैसे रेगुलेट करता है, लॉन्ग टर्म कंट्रोल हमारा जो कैसे होता है. दोज थिंग्स आर through the kidneys, through the system, and pressure diuresis कैसे होता है, we have seen that. And then now we will go into the RAS, renin angiotensin aldosterone system, and then we can understand the central osmoreceptors, which is also very important, how things happen in your blood pressure. So let's understand. So what is renin angiotensin aldosterone system, right? And why it is important to preserve your intravascular volume, ठीक है, blood का volume, and the mean arterial blood pressure, how it actually affects them. Let's understand. RAS is renin angiotensin aldosterone. तो यहाँ पे ये क्या करता है, प्राइमरीली ये एक्टिवेट होगा. So this will activate only when the renal blood flow is low, if kidneys do not receive sufficient amount of blood. So this is the prime factor. ठीक है. अब renal blood flow अगर आपका just because of हाइपोटेंशन कम हो जाता है, इंट्रावैस्कुलर वॉल्यूम कम हो जाता है, डिहाइड्रेशन हो जाता है, कहीं से ब्लीडिंग हो, इफ देयर इज अ ब्लीडिंग, इफ देयर इज अ ब्लॉकेज, इफ देयर इज एथेरोस्क्लेरोसिस, रीनल आर्टरी स्टेनोसिस, इन एनी वे, if your kidneys do not receive specifically the afferent arterioles do not receive a sufficient amount of blood, मतलब juxtaglomerular apparatus है वहां पर एक, and that juxtaglomerular apparatus which if does not receive sufficient amount of blood, it just activates your renin angiotensin system. So the idea is that kidney have their own system to increase blood pressure. है, किडनी के पास अपना सिस्टम, मेरे पास खून नहीं आ रहा, मुझे खून दो, राइट? वो बोलता है तुम मुझे खून दो, मैं तुम्हें यूरिन दूंगा, है कि नहीं? तुम मुझे खून दो, मैं तुम्हें आजादी तो नहीं दे सकता, यूरिन दूंगा. सो juxtaglomerular apparatus जो है, ये भैया जो है, this particular system says if I don't get blood, I will secrete renin, I will give renin. So they basically secrete renin, and what this renin does, it initiates a whole set of mechanism, right, through which ultimately, and देखो renin angiotensin बाद में क्या आ रहा है, तो renin के बाद it just produces more angiotensin. So how is that produced? Renin is produced by what? It is produced by this juxtaglomerular apparatus. So juxtaglomerular apparatus is important here. Afferent arteriole is important. What is the stimulus? Renal blood, decrease renal blood flow through any cause. I don't care. The juxta उसको कोई फर्क नहीं पड़ता, right? If you want food, you don't care where it is coming from, right? That's how it is. So what it does is, whenever there is renal hypoperfusion, there will be increased renin. There is something called as angiotensin, which is converted to angiotensin 1 through renin, and there is something called as ACE, right? ACE, which is the pulmonary vasculature, produces these ACEs, and this ACE inhibitors are there, right, which we give in high blood pressure. हम ये देते हैं दवाई, ACE inhibitors, enalapril or ramipril, all these things are given. ramipril, enalapril, right, ये हम देते हैं to reduce blood pressure. इसका भी मैकेनिज्म समझेंगे, बट हियर व्हाट वी आर अंडरस्टैंडिंग इज कि एंजियोटेंसिन से एंजियोटेंसिन 1 एंड एंजियोटेंसिन 2, अल्टीमेटली रेनिन प्रोडक्शन इंक्रीज होता है तो एंजियोटेंसिन 2 इंक्रीज होता है. So this is what is the end mechanism. Renin increases angiotensin 2. Now what does angiotensin 2 does, or why it is important, right? First clinical note पे हम आएंगे, but we will understand first what angiotensin 2 does. Okay, angiotensin 2 ultimately try करता है to increase blood pressure. How does angiotensin 2 tries? It basically will stimulate the sodium reabsorption. तो अगर आपके बॉडी आपकी, if your kidneys basically reabsorb the sodium which is getting excreted, it will also reabsorb water. So angiotensin 2 reabsorbs sodium. This is the prime thing which you need to remember. Renin fluid blood flow पे एक्टिवेट होता है और एंजियोटेंसिन 2 बनाएगा. रेनिन से एंजियोटेंसिन 2 से सोडियम रीएब्सॉर्ब होगा, पानी रीएब्सॉर्ब होगा, और साथ में देयर आर टू मेथड्स हियर. दिस इज जस्ट वन मेथड. द सेकंड थिंग इज बिग सिस्टमिक वैसोकंस्ट्रिक्शन. तो वैसोकंस्ट्रिक्शन करता है ये. It is also very important. It also causes powerful systemic vasoconstriction. So if it constricts the vessels, it will increase the blood. वो खून की नसों को दबाता है, भैया मेरे को खून दो. So it increases the blood flow to the kidney. and sodium reabsorption increases the volume of the blood, so it expands the intravascular volume. And where does it act? It acts in the proximal nephron. तो ये proximal nephron पे act करता है angiotensin 2, और ये आपकी प्यास भी बढ़ाएगा. It will stimulate thirst. Obviously thirst will be stimulated somewhere in the brain, है ना, दिमाग में कहीं act करके. So this will be in your hypothalamus. तो हाउ वन एंजाइम इज एक्टिंग इन सो मेनी प्लेसेस. वन, ये खून की नसों को सिकुड़वा रहा है, वैसोकंस्ट्रिक्शन, सोडियम रीअब्जॉर्प्शन एंड हाइपोथैलेमस फर्स्ट सेंटर्स आर एक्टिवेटेड, and sodium reabsorption is through proximal nephron. A simple concept here, right? So अब इसमें the issue is that this particular process of increasing the blood pressure is not rapid. It is not rapid, ठीक है? Because मतलब there are two methods. Why does you need two methods? Because this method, sodium reabsorption, will take hours. It will take hours to act. So this is not, or days, hours or days to act, and this vasoconstriction is instant. Okay, is instant. So that's why there are two methods. कि immediate मेरे पास खून नहीं आ रहा, we cannot allow the kidneys to shut down. Okay, so वो किडनी को shut down नहीं होने देते. If you are getting the answer, समझ में आ रहा है तो प्लीज इसमें कमेंट करिए. लाइव चैट में देख रहा हूँ कि कोई क्या पूछ रहा है. So if you can ask questions, if you want to ask questions, you can ask questions in the live chat. Please do that. Okay. Or here the problem comes is कि sodium reabsorption will increase the volume in a long period of time, and that volume will stay there, right? Volume will stay there. So this is not always a easy way. Why this is made like that? ये क्यों ऐसा बनाया? क्योंकि अगर instantly volume आएगा, maybe the hypotension is caused because of a vasovagal syncope. Maybe there was a temporary hypotension because of some reason, and वो थोड़ी देर में ठीक हो जाए. एंड वो थोड़ी देर में अगर बहुत सारा वॉल्यूम आ गया, अल्टीमेटली योर बॉडी विल एंड अप इन अ वेरी हाई वॉल्यूमिक स्टेट, हाइपर वॉल्यूमिक, एंड इफ you have you can go into a volume overload. If you have a initial, any kind of cardiomyopathy or heart failure situation, it can precipitate. So your body will not increase the system, which cannot be reversed easily. अगर excretion की बात करें, water excretion is not, you cannot do immediate water excretion very fast. Ultimately 1 घंटे में आपकी बॉडी 100 ml, 200 ml, 300 ml, नॉर्मली 50 to 200 300 ml ब्लड यूरिन निकालती है. तो 1 आवर में आप वाटर भी उतना है या उसके आसपास ही रीअब्सॉर्ब कर सकते हो. यू कैन नॉट जस्ट ट्राई टू रीअब्सॉर्ब लाइक 1 liter of blood, but you can just transfuse 1 liter of volume if you want. So that's why ये system slow है. Why I am telling you this? So that you will never forget that why sodium reabsorption system is slow method of actually correcting your blood pressure, and this vasoconstriction is a rapid method of correcting blood pressure. That's why in a case of acute hemorrhage, acute hypovolemia, this acute rapid rise in atrial blood pressure is also done by this vasoconstriction effect of your angiotensin 2. So angiotensin 2 ये करता है, ये देख लीजिए. एक तो angiotensin 2 आपके वेस्कुलर स्मूथ मसल्स पे vasoconstriction करेगा. दिस इज वेरी फास्ट. ओके. देन हाइपोथैलेमस को थर्स्ट इंक्रीज करेगा. दिस इज ऑल्सो अ गुड मेथड विच विल बी ओके. किडनी का सोडियम रीएब्जॉर्प्शन वो बढ़ा देगा. इट इंक्रीजेस द सोडियम रीएब्जॉर्प्शन एंड it will act on your adrenals also. On the adrenal gland it will increase the aldosterone secretion. इसीलिए रेनिन एंड एंजियोटेंसिन एल्डोस्टेरोन एक्सिस बोलते हैं. So aldosterone is another aspect here, which in turn also increases the sodium reabsorption. So sodium reabsorption is done directly by the angiotensin and indirectly also. दो मेथड से. तो aldosterone क्या करता है? एल्डोस्टेरोन सोडियम रीअब्जॉर्प्शन करता है, बट दिस एक्शन ऑफ एल्डोस्टेरोन इज इन द डिस्टल नेफ्रॉन. अब ये भाई साहब डिस्टल ही एक्ट कर रहा है, एंजियोटेंसिन प्रॉक्सिमल पे एक्ट कर रहा था. तो यहां पर ये दो इफेक्ट करता है, नॉट जस्ट सोडियम रीअब्जॉर्प्शन. दिस इज ऑल्सो अ बिग इंपॉर्टेंट वर्क. पोटेशियम सिक्रीशन. So if your potassium is secreted, by the aldosterone. This way you can do a lot of good. ये पॉइंट को आप बहुत अच्छे से यूज कर सकते हो और करते हो. क्यों करते हो, कहां करते हो, बताते हैं. देखो, बिकॉज सोडियम रीअब्जॉर्प्शन होगा तो ऑब्वियसली वॉल्यूम बढ़ेगा, वाटर रीअब्जॉर्प्शन होगा, सो दिस विल बी बेनिफिशियल इन हाइपोवॉल्यूमिक स्टेट. सो इंक्रीज इंट्रावेस्कुलर वॉल्यूम हो रहा है, मेंटेनिंग ब्लड प्रेशर हो रहा है, दिस इज ऑल्सो गुड. नाउ here what it does is it will also cause, agar if you have if you have this can lead to hypertension because of volume overload. Electrolyte imbalance is big issue. Hypernatremia, increase in sodium. It can cause hypokalemia, decrease in potassium because the potassium is excreted. So potassium agar excrete ho raha hai, hypokalemia ka risk hai. So we can actually use some blockers here so that ये method जो naturally होता है वो हम block कर सकें, right? Why? And then it can lead to this metabolic acidosis or as metabolic alkalosis, right? Metabolic alkalosis, the positive ions are increasing here, है ना? So that's why. So what is the actual application here? First application हम ये देख सकते हैं कि ये वाला, कि इन अ क्लिनिकल नोट जब भी कभी देयर विल बी hypovolemia, the RAS will be activated, we know that, but it is not compulsory for कि hypovolemic हो तभी RAS activate हो. किसी euvolemic state में या hypervolemic state में भी RAS activate हो सकता है, मीनिंग कि ब्लड में वॉल्यूम है मगर किडनी को नहीं पहुंच रहा है. दैट इज अ बिग इशू. ब्लड में वॉल्यूम है मगर किडनी को नहीं पहुंच रहा है. मे बी यू हैव रीनल आर्टरी स्टेनोसिस, मे बी योर हार्ट इज नॉट एबल टू पंप properly. Okay, these are the two methods. So here in this case, if kidney is under perfused, again the renin RAS system is activated, again the sodium is reabsorbed, and in this case it will be more problematic because volume already ज्यादा है या यू वॉल्यूम है और already हार्ट के ऊपर आप उसका प्रीलोड बढ़ जाएगा. So this will increase the preload if in this situation RAS is activated. So here a long-term RAS will not be a good appropriate response. That's why this can actually lead to an issue, right? So we need to block the RAS here in cases of congestive heart failure or in cases where blood pressure is intractable blood pressures. Because if RAS renal artery stenosis होगा, so blood pressure आराम से कम होगा ही नहीं, because there will be a chronic this kind of a thing, right? Volume overload, sodium overload because of this RAS method. So here we have seen that RAS में ACE enzyme का बहुत important role है. So if we can inhibit these ACE enzymes by the use of angiotensin converting enzyme inhibitors, right? By using the inhibitors, then we can actually reduce the amount of angiotensin II and the aldosterone. So we reduce the amount of both the things which reabsorb sodium. So we reduce the amount of aldosterone and angiotensin II is inhibited by the ACE inhibitor. So इसके वजह से ultimately sodium is excreted more, volume is excreted more, so your blood pressure is reduced because the even in heart the preload is reduced, तो heart को थोड़ा आराम मिल जाता है. That's why it's a very important medication in cases of heart failure or even in case of high blood pressure. ACE inhibitors or ARBs, angiotensin receptor blockers. So ACE inhibitors inhibit angiotensin to get formed और angiotensin जहां पे एक्ट करते हैं उस रिसेप्टर को ही ब्लॉक करें. So ARBs will, these both the cases will actually act on the same thing, the same enzyme. Okay, so that's where it is important. उसके बाद में एल्डोस्टेरोन का जो important है कि रीनल आर्टरी स्टेनोसिस तो एक कॉमन कॉज है ही जिसमें आपका हाइपरटेंशन होगा, लेकिन कुछ ऐसे केसेस जैसे प्राइमरी हाइपर एल्डोस्टेरोनिज्म is also one case where it is getting more and more prevalent. What does that mean? Because aldosterone can be secreted in an excess amount in these individuals, and because aldosterone is high, these individuals will have high sodium concentration in the blood, and they will have high volume of blood, and ultimately they will have high blood pressure. So if you are having high blood pressure, एक hyperaldosteronism is also one case where spironolactone will have an important role. A diuretic, again diuretic दे रहे हैं, right? Diuretic का रोल आ जाएगा. तो अगर किसी पेशेंट का वॉल्यूम ओवरलोड है, कंजस्टिव हार्ट फेलियर है, या हमें डाउट हो रहा है कि उसके केस में सोडियम रीएब्जॉर्प्शन या सोडियम ज़्यादा आ रहा है बॉडी के अंदर, volume ज़्यादा आ रहा है, in that case a diuretic is preferred, and in this case we have to make sure that we are giving a spironolactone kind of a diuretic which is an aldosterone antagonist, because or else पोटेशियम बहुत ज़्यादा आपका एलिमिनेट हो जाएगा. पोटेशियम एलिमिनेट हो जाएगा तो बहुत दिक्कत हो जाएगी, बिकॉज अ लॉट ऑफ पोटेशियम इज एलिमिनेटेड बाय डायूरेटिक्स एंड द पेशेंट अल्टीमेटली लीड टू हाइपोकैलेमिया. तो हाइपोकैलेमिया इज ऑल्सो वेरी हार्मफुल फॉर योर हार्ट. रिदम प्रॉब्लम्स उसमें आने लग सकते हैं. सो वी डोंट नीड दैट, है कि नहीं? So this is very important concept. Now let's understand the concept of osmoreceptors and why antidiuretic hormone is important. ADH is also some antidiuretic hormone जो आपके ब्रेन से आता है ना. ADH is a hormone. ADH जिसको हम वैसोप्रेसिन भी बोलते हैं, बिकॉज इसके दो काम करता है. वन इज दैट जैसे एंजियोटेंसिन 2 और ADH, they are very similar. Angiotensin 2 क्या कर रहा था? Angiotensin 2 had two work. One was that it causes sodium reabsorption, sodium plus water retention और reabsorption, right? Same ADH करता है. ADH भी आपका water reabsorption करता है, लेकिन सिर्फ water करता है, सोडियम नहीं करता. ठीक है? Here ADH is doing water reabsorption only, not sodium. Aldosterone is doing both sodium and water reabsorption. Angiotensin also does vasoconstriction. ADH also does vasoconstriction. So फर्क इसलिए मैं बता रहा हूं, so that you can remember that ADH acts by stimulating the water reabsorption, because the mechanism is not through sodium reabsorption. Therefore the action is in the collecting tubules. It's in the collecting tubules of the distal nephrons, not in the any other in the angiotensin 2 acts on the proximal tubules. तो यहाँ collecting tubules पे act हो रहा है, not in proximal. and यहाँ पर dosage फर्क पड़ता है. ADH in low dosage causes water reabsorption, and ADH in high dosage causes vasoconstriction. So remember the dosage issue here, right? So ADH इसीलिए और vasopressin भी कहते हैं. This person is also called vasopressin, and it is given in cases of hemorrhage or non-cardiogenic shocks. In non-cardiogenic shock or kind of a hemorrhage, hypovolemic shock, you can actually give vasopressin because it can act on high doses, and this can also be given in as an infusion because it causes vasoconstriction and causes water reabsorption, thereby increasing the volume and the blood pressure. So in a patient with shock, non-cardiogenic shock, ADH or vasopressin can also be given, which basically increases the blood pressure. तो blood pressure ये भी बढ़ाता है. Here we just see that if you talk about ADH, right? ADH has its own sensitivity of regulation. ADH posterior pituitary से आता है, हमने देख लिया. वो water reabsorb करता है, वो vasoconstriction करता है, low dose में water, high dose में ये. But who basically stimulates ADH secretion, right? रेनिन का सिक्रीशन हमने देखा, रीनल ब्लड फ्लो कम हुआ, रेनिन सिक्रीट हुआ. ADH किसने सिक्रीट करा दिया? ADH को कौन सिक्रीट करा रहा है? एंड व्हाट इज दैट मेथड? द मेथड इज कॉल्ड अ ऑस्मोरिसेप्टर. So there are osmoreceptors located which are there in hypothalamus in your brain. So hypothalamic osmoreceptors ऑस्मोटिक प्रेशर, ऑस्मोलैलिटी चेक करते हैं आपके ब्लड की. तो वट एवर ब्लड ग्लोज इन टू द ब्रेन, योर ब्रेन डिटेक्ट्स हाउ मेनी सॉल्यूट्स आर देयर in how much volume of blood. This is what they detect, right? So this, for example, say this is the normal osmolality of blood which is getting into the hypothalamus. And in one situation, what happens if the osmolality it gets concentrated? So if agar wo volume of blood becomes more, so here what is happening? Here the osmolality has increased, but the volume of blood is less. Here the volume of blood is more and the osmolality will be less. Because it's same. Here the volume is increased, here the volume is decreased and the osmolality has increased. तो मतलब ऐसे केस में जब सॉल्यूट्स बढ़ जाए या मान लो इलेक्ट्रोलाइट्स बढ़ जाए, तो ऐसे केस में दिस पर्टिकुलर सिस्टम ADH will react very fast. ADH की मात्रा आपके पिट्यूटरी से जल्दी आएगी. ऑस्मोरिसेप्टर्स will act very fast like this in a straight line manner. ठीक है. For example, percentage change in the osmolality. This one is the osmolality. एक टाइम पे वहां पर नॉर्मल थी, 0 थी. If just 5% osmolality changes, तो यहां पर देख सकते हैं आप आपके सीधा ADH लेवल जो है वो जो नॉर्मल से या इधर 0 के आसपास 543 के आसपास थे 3 पिकोग्राम, वो सीधा 20-18 पे पहुंच गए. Just 5% of change. But in case of just 5% increase in the blood, in the volume of in the plasma volume, it does not lead to any change of ADH. तो ये प्लाज्मा वॉल्यूम का है, ये वाला है वॉल्यूम का, and this is the solute osmolality kind of osmotic pressure. तो नंबर ऑफ सॉल्यूट जब बढ़ते हैं तो बहुत तेजी से आपका ADH डिक्रीज होता है, ADH इंक्रीज सिक्रीट होता है. और वाटर जब बढ़ता है तो इनिशियली कोई दिक्कत नहीं आती, आगे चल के एक लेवल के बाद जब पानी की मात्रा बहुत ज्यादा बढ़ जाती है तब आपका ADH सिक्रीट होता है. तो द ग्राफ इज समथिंग लाइक दिस. So ADH, also called vasopressin, exerts its effect through two different receptors. First, its vasoconstrictive effect is mediated by a receptor called AVPR1A, located on the vascular smooth muscle cells, and its effect on renal water reabsorption is by the receptor AVPR2 on the renal tubules. So the loss of function of this later receptor, this receptor actually results in nephrogenic diabetes insipidus. Insipidus diabetes कैसे होती है? Because of the loss of receptor AVPR2 in the renal tubules. इसके वजह से nephrogenic diabetes insipidus हो सकता है. So remember this receptor name for diabetes insipidus. Now let's talk about this low pressure stretch receptors that are monitoring venous return. इसके अलावा now we have understood RAS. ये वाला जो स्ट्रेस रिसेप्टर है इसको भी शॉर्ट में देख लेते हैं, because we have, I think we have seen this. And we will not talk about this, sir. We will see this. Okay. Low pressure stretch receptors कहाँ हैं? Low pressure means if at all there is a reduced blood pressure. Kidney is responding to reduced blood pressure, ठीक है, by increasing renin. Now there are other receptors, low pressure receptors in the atria and in the atrium. In both the atriums, whenever the blood pressure is low, they will secrete atrial nitriuretic peptide. Nitriuretic peptide, they are one, and this is also present in vena cava. ठीक है. अगर if large volume of blood आता है, अगर large volume of blood आता है, these receptors send signal through vagus that stimulate selective renal vasodilation causing diuresis. तो ये अगर आपका, why do you say these are stretch receptors, not on low blood pressure, these will act on the volume. These will act on the volume of blood which is coming into the atrium. Stretch receptors हैं. लो प्रेशर का मतलब है इवन इफ अ लिटिल प्रेशर इज इंक्रीज्ड, ऐसा नहीं कि बहुत ज्यादा स्ट्रेच होगा तभी सिक्रीट होगा, नहीं, थोड़ा सा भी प्रेशर इंक्रीज होगा तब भी ये सिक्रीट होंगे, एंड दे विल लीड टू डायूरेसिस. डायूरेसिस मींस इंक्रीज इन द वॉल्यूम ऑफ एट्रियम, मे बी राइट एट्रियम लेफ्ट एट्रियम का स्ट्रेच होता है, तो वो स्ट्रेच इंक्रीजेस एएनपी स्टिमुलेट्स द वेसल excrete, basically diuresis from the kidney trying to decrease the blood volume by one way. This is one way of handling the situation. The second way is that it will basically, because the venous return is increased, there are these receptors in the arteries, in the aorta, atrium, stretch receptor, they also increase the heart rate by a Bain-Bridge reflex. And this Bain-Bridge reflex intends to increase the cardiac output. Cardiac output बढ़ेगा, so अपने आप वो जो volume आया है वो बाहर निकलेगा. So these are the two methods where atrial stretch from the venous return causes atria to secrete this ANP and this venous return. There is something called as BNP also, which is the similar thing which is secreted by ventricles. ये ventricles से secrete होता है, although नाम brain natriuretic peptide है, मगर ये cardio neuro hormone है secreted by ventricles in response to volume expansion या pressure overload. Whenever there is pressure overload and the ventricles are not able to handle, overstretching, they will be a sign of, that will be a sign of volume overload or left ventricular heart failure. So BNP will increase. Whenever there is a BNP high, the idea is that you need to do some amount of diuresis. So diuresis has to be done. ठीक है, अगर BNP हाई है, so that ventricles का जो volume stretch हो रहा है वो ना हो. This is the idea. Now let's understand something about fluid exchanges in the capillaries. Fluid exchange across the capillary membrane. Capillaries means the smallest of the blood vessels which are there inside the tissues. ठीक है, these are just like ये होती हैं छोटी छोटी ड्रेन्स है, नालियां हैं जो घर के आसपास होती हैं, बिल्कुल चिपक चिपक के आपके सेल के बगल बगल से निकलने वाली कैपिलरीज. तो क्या हो रहा है यहाँ पर, व्हाट इज द फ्लूइड एक्सचेंज गोइंग ऑन इन द कैपिलरीज? लेट्स अंडरस्टैंड दिस. Whenever there is a fluid exchange across the capillary membrane, it depends upon one, permeability of that capillary bed, and the net filtration pressure gradient, है ना? प्रेशर ग्रेडियंट बोलेंगे, क्या बोलेंगे? प्रेशर जनरेटेड अक्रॉस द कैपिलरी बेड. अंदर प्रेशर ज्यादा है कि बाहर प्रेशर ज्यादा? वन इज परमिएबिलिटी, सेकंड इज प्रेशर. तो व्हाट इज दिस नेट फिल्ट्रेशन प्रेशर? विच डिपेंड्स अपॉन कि आपके प्लाज्मा के अंदर उधर एरिया में ऑस्मोटिक फोर्स कितना है. अगर आपके एक टिश्यू है, एक कैपिलरी है, इफ द कैपिलरी हैज मोर नंबर ऑफ सॉल्यूट्स, it will suck the fluid from the cell. If the capillary has, so why? Because the solutes, they demand more fluid. Sodium ज्यादा होगा तो पानी खींच लेगा, है कि नहीं? Same way, ये क्या हो गया? This is the filtration pressure generated because of the osmotic forces. If the solute has very less amount of maybe the particles and a lot of fluid, the fluid will go into the cells. This is what happens in very classical cases of hypernatremia and hyponatremia. In hyponatremia, what happens? The fluid basically goes inside the cells. RBCs फूल जाते हैं, cells फूल जाते हैं, और जो सोडियम बढ़ जाता है तो सारे cells shrink हो जाते हैं. All the volume comes back into the intravascular volume. This is what happens. So this is the osmotic force net filtration pressure, which is also known as Starling's force. एक होता है Starling's law, एक होता है Starling forces. The end result of this interaction is the production of the net filtration pressure that derives the fluid from the capillaries into the interstitium or from the interstitium into the capillaries depending upon relative contribution of the force. This is what I explained. Now, क्या है Starling forces? Hydrostatic pressure of capillaries. Starling force कहता है it is the outward force exerted by the pressurized fluid within the blood vessel, and it is greater on the arterial end of the capillaries, which is approximately 35. That is on the venous end, it is 15. What does that mean? एक कैपिलरी हमने देखा है कि ये आर्टरी आती है और ये वेन जाती है और बीच में हमारे बथेरी सी बहुत सारी छुटपुटाई छोटी छोटी कैपिलरीज है. So at this end the pressure is high, 35. At this end of these capillaries the pressure is 15. That's why the flow of blood is in this direction from high pressure to low pressure. This is what it is saying. So when this pressure is there from high pressure to low pressure, जो capillaries हैं उनके wall पे भी pressure है थोड़ा. So capillaries have pressure through the wall within the blood vessel, and that pressure can push a little amount of fluid outside, right? That is the hydrostatic pressure, not the osmotic pressure. Osmotic pressure is because of the particles inside the blood, है ना. यहाँ पर osmotic pressure की बात नहीं है, hydrostatic pressure की बात हो रही है because of the pressure gradient. Hydrostatic pressure difference along the capillary results in the net loss of fluid from the arterial end and reabsorption of interstitial fluid from the venous end. So this is how it is. Conditions of venous obstruction and hydrostatic pressure may become abnormally elevated because that results in loss of fluid into the interstitium causing edema. इसको भी समझाते हैं. See, here we can see that this is the arterial end, this is the venous end, and here there is a lot of capillaries. There are a lot of capillaries which are here, and here we can see कि arterial end पे जो hydrostatic pressure आ रहा है that was 35, pushing the blood outside, pushing some water or fluid outside. But there is some osmotic pressure also. Consider that osmotic pressure is like it is pushing the water content inside, pushing the this inside, because यहाँ पर may be solutes थोड़े से कम है. ठीक है. So 25 mm of Hg के pressure से, so the gradient here will be positive 10 mm of Hg. Ultimately some amount of fluid will be lost in the capillaries. That means net transudate बनेगा. Transudate बनेगा यानी fluid आपके tissues में जमा होगा. Net transudation is 10 mm of Hg का at this starting point of capillaries. At the midpoint of capillaries, hydrostatic pressure is 25, osmotic pressure is 25. There is no net movement. ये zero movement है. At this end of these capillaries, hydrostatic pressure is 15, osmotic pressure is 25. ये क्या हो गया? Net reabsorption. यानी यहाँ पे 10 mm से बाहर गया, यहाँ पे 10 mm से अंदर गया. Ultimately, all is well. So here, these normal systems work. अच्छा, can you repeat what is hydro? Do you want me to repeat in English or Hindi? Kabir, tell me. English or Hindi? English or all right. So let's understand what is hydrostatic force. Consider if you have a single pipe. If you have a pipe, and in that pipe you have connected one part into a tap. So you connected one part of pipe into a tap, the other part is open. Okay. Now what happens if you open the tap? If you open the tap, there is a free flow of water or whatever is there in the tap outside like this. Okay. So if you basically make a hole here, make few holes here in the pipe, what do you think will happen? What do you think will happen? If you make a few holes in the pipe, this water will also try to come out from here. Although it has a bigger hole outside, right? there is a big huge hole which is free of any pressure, but still a little amount of blood will try to come out here. And if you compress the pipe from front, then a lot of pressure will come out from here. Lot of water will come out because the pressure increases. This particular pressure which the water is exerting into the wall of the pipe is the hydrostatic pressure, the sheer pressure of flow of fluid, right? Sheer pressure of flow of fluid, because of which if the fluid does not have space to go in the side, it goes in the front, right? Why is the fluid going, why is the fluid not just stagnant there? Why is the blood not stagnant here? Because it has 35 mm of Hg pressure, which is trying to push the blood in all directions, right? In the backward direction it cannot go because from here the pressure is generated. In the side direction it has a wall, that's why it has nothing, nowhere else to go but here. But in the side direction it will create a pressure on the wall, and if the wall is semi permeable, then a little amount of fluid will leak. The semi permeability means that your pipe has some dots. That's what it means. A semi permeable, a normal pipe which is there, plastic pipe in your house, is not permeable, but if you make a lot of dots it will become semi permeable and it will leak a little amount of water, and then you will have a lot of water in your house on the floor, and then you will get a lot of scoldings. Okay, I hope you got it now. Did you understand the hydrostatic pressure? So hydrostatic pressure is the sheer force of fluid moving into a closed chamber, which basically puts pressure on all walls. Obviously the pressure is more towards this direction, that's why the flow of blood is here. Okay, very nice. That's what I want from you. Just ask questions and I'll clear the doubts. Very good. So here there is a net hydrostatic pressure, and again let me tell you that this is not a fixed pressure. When I say there is 35 mm of Hg of pressure in the arterial end, does not mean everywhere in the body there will be only 35, it will never change. No, obviously whenever there is a high blood pressure, right, maybe there is a high blood pressure, this pressure will increase. If arterial pressure increases, why not the pressure which is hydrostatic pressure increased, which is exerted here, will increase? Same, the venous pressure will increase. There are many more mechanisms. Say the artery is compressed from here. If the artery which is coming here is compressed because of some tumor or something, right? Or it has an atherosclerotic patch here, big atherosclerotic plaque here. Again, the flow is obstructed. Because of this obstruction, the volume of blood will reduce. So ultimately, the volume of blood which is coming here will reduce. So this pressure can reduce. Because the flow is less, this flow can reduce. So a lot of factors apply to every single capillary bed in your body, and this pressure can change. Same thing goes with here. The hydrostatic pressure exerted by your tissues, right? Or this is the blood vessel, right? There are some amount of sodium, potassium, and all the solutes present here. And what is this? This is the interstitial space. Interstitial space of the lungs or the heart or the legs, right? Interstitial of the legs, where the muscles and soft tissues or skin tissues are there. So if that interstitial tissue has a lot of, it has very less solute, it has a less amount of sodium, say it has like only a less amount of, what will happen? The water inside this interstitium will try to push the water back into the, because sodium is less here, it's more here, so it will try to push the water back into the blood vessel. That is what is called as osmotic gradient. So osmotic gradient can also change throughout the system depending upon how much concentration of that osmotic particles are there inside that interstitium of the cell and inside the blood vessel, right? So these gradients change, but this is just an example how the osmotic, there are two basic forces which determine what kind of transudation will happen and what kind of reabsorption of that transudation will happen. So this transudate, if it is more, what will happen? You will have edema, right? If you have a lot of transudate, that means either hydrostatic pressure is more or the osmotic pressure which is pushing the blood is less. Osmotic pressure is less, right? Say if this particular tissue has a lot of sodium or some kind of other solute particles which changes the osmotic gradient, so kya hoga? Edema ho jayega. So why we say that the patient might have water retention, might have a lot of sodium. Say if your blood has hyponatremia, it has less amount of sodium or it has less amount of albumin. So what will happen? Because of less albumin, it just pushes all the blood outside jahan bhi possible hai, wherever there is a possible, you will have anasarca, you have swelling all over the body, right? So it will basically push blood everywhere. So this is the importance of these two forces. And in conditions where there is very rapid loss of intravascular volume such as hemorrhage, what will happen? The hydrostatic pressure of capillaries become very low because there is no volume. There is no volume, decreased blood pressure will decrease the hydrostatic pressure, right? So which will very low to cause fluid movement into the interstitium. Instead, the net movement of interstitial fluid into the capillaries will increase. So hydrostatic pressure kam ho gaya, the body will try to shrink all the tissues and take away all the fluid which is there inside the tissue. So fluid सारा आपके volume में आने लगे, which will also help restore the blood volume. That's why there is a drop in hematocrit in many hours after an acute bleed. Plasma oncotic. What is plasma oncotic pressure or plasma colloidal osmotic pressure? ये दो बड़े important aspects हैं. We will understand this and then we will understand the interstitial. Okay. What is plasma oncotic pressure? This is the inward force on the fluid movement exerted by the plasma proteins. Okay. So we are talking about oncotic pressure is the pressure of the solutes. And in case of plasma oncotic pressure, it is the pressure of the solutes. That solute is plasma protein. So these are very large to diffuse out of the capillaries. So these things, they generate an oncotic pressure and actually draw fluid from the interstitium into the capillary. So they will, that's why the oncotic pressure, it takes the fluid from the capillaries into the blood. One big factor is this. And plasma albumin is the primary determinant of plasma oncotic pressure just because of the number of molecules. Albumin levels are high. Number of molecules of albumin is higher than number of globulin. Albumin is greater than globulin. And technically, globulin is a better oncotic agent. It will create more oncotic pressure if it was in a higher concentration, but albumin is in the higher concentration. Remember this for MCQs. Globulin ke bare mein. And there are two plasma protein, albumin or globulin. So patients with a case of hypoalbuminemia, this oncotic pressure which is pulling the blood, pulling the fluids inside the blood vessels will reduce, and ultimately fluid will move from the vascular compartment into the interstitium, leading to edema. So one cause of edema is plasma oncotic, low albumin, low plasma oncotic pressure. What about this is also called as plasma colloid osmotic pressure, oncotic or colloid. Colloids are the protein. Albumin is, albumin is basically all the proteins which you eat, all they are broken down into amino acids and they go into your liver. And albumin is synthesized from these amino acids into the liver. Therefore, Any case where you do not give amounts of amino acid to your liver to create albumin can lead to hypoalbuminemia, and that can lead to edema. So hypoalbuminemia, having less protein in your diet, can actually lead to edema. And then there are some kidney syndromes like nephrotic syndrome, in cases where you basically lose a large quantity of serum proteins in urine, which can also lead to hypoalbuminemia and edema. Okay? So albuminemia is the main thing. The fluids that is directed into the interstitium is called the transudate, and this transudate, which is basically protein poor, transudase is protein poor and cell poor fluid, because it is very low viscosity and it basically obeys the laws of gravity and collects in the most dependent portion of the body, which is the feet in the patient is standing up, or if you put a gentle pressure on that area, it will be a pitting edema. Okay, so that's why high protein diets are important. What is interstitial hydrostatic pressure? Now, hydrostatic pressure is the shear force of fluid pressure. Yes, liver failure will cause edema. Liver failure causes a lot of edema, and even the liver causes a lot of ascites, if you remember. It causes a lot of ascites, a lot of fluid. It basically goes inside the patient becomes dehydrated. There are many more uh, things going on in a liver disease patient. So patient becomes dehydrated. So ultimately, this particular force will definitely increase uh, the plasma oncotic pressure. So interstitial hydrostatic pressure. So interstitial hydrostatic pressure क्या है? Interstitial fluid exert an inward force. ठीक है? Fluid will exert an inward force. The force is normally slightly negative because the lymphatics are constantly draining the interstitial fluid. So what does that mean? It means that this is the blood. This is the blood vessel or a capillary, whatever it is, and this is the interstitium of the cell, per se your leg. So this leg will have this blood vessel will have an hydrostatic pressure pushing the fluid outside, and this interstitium के अंदर में भी जो fluid है, it will have a negative hydrostatic pressure, meaning it's not only sucking in the blood. Why is it negative? Because there is another outlet of this fluid going out, which is the lymphatic system, right? For example, if you put a pipe inside a bucket, and that pipe has a lower end outside, correct? Then the water can actually come down. Once it is started, it will have a negative pull and the water will drain out, है ना? याद है कैसे निकल जाता है नेगेटिव? तो uh, this particular hydrostatic pressure of the fluid present in the interstitium will have a negative pressure inward pull from the blood vessel, because it is being because there is an outlet here into the lymphatic system which is continuously drained. What is interstitial oncotic pressure? The same area here, which is your tissue and a lymphatic system, whatever is there. This particular tissue has some amount of, because the proteins, some amount of proteins present in the tissue, right? So interstitial proteins are also present. These interstitial proteins, the albumin, which gives the protein, gets absorbed into the muscles, or proteins which are absorbed into any tissue. Say every single tissue does some amount of repair or regeneration or even fibrosis. Any kind of tissue is made up of amino acids, proteins, right? fats, proteins, lipoproteins. Cell wall is made up of lipoproteins. So every single cell, new cell, regeneration of the cell needs protein. So obviously it's filled of protein. So if the number of proteins are high, interstitial protein is high, again they will have a oncotic pressure, which will be a outward force. That's why the force of oncotic pressure from the blood vessel to the from the interstitium to blood vessel is outward inside the blood vessel. Okay? The concentration of protein in interstitium is normally much less than that of the plasma. So this force is a less than the opposing force of capillary oncotic pressure. So in the plasma, sorry, because this will be a force, outward force exerted by the. I think this is wrong. This would not be an outward. This would be an inward force, है ना? Because ultimately proteins will, if you are oncotic pressure की बात कर रहे हो, तो comparison में तो yes, the net force will be outward, right? Because the capillary oncotic pressure is much more. So net force is outward, but the force which if individually force देखोगे तो ये inward आएगा. What about this? Inflammation status. In inflammatory states, increased हो जाता है vascular permeability, which basically results in increased level of interstitial protein, which increases the interstitial oncotic pressure and derives the fluid into the interstitium, causing edema. So this is the inflammation, increased permeability. Therefore, there will be increase in interstitial oncotic pressure because of the increased proteins. So it drives the interstitial protein बढ़ जाएगा तो वहां पर और ज्यादा खींचा जाएगा. So yes, it is there. Types of fluid, here it is rich in protein. Okay, so that's why this particular edema, in case of inflammation with increased permeability, it has more proteins and it is called a exudate. Exudate is in inflammation and transudate is in no inflammation, where the permeability is not so much high. So why there is increase in proteins? Because there is a leakage of proteins in inflammatory state. Ultimate point यहाँ पर क्या है? Ultimate point है कि in inflammatory state, not just the fluid, the proteins leak into the tissues. So proteins are leaking from blood into the tissues. Therefore, the exudate is just infiltrate the plasma, transudate plus proteins. Transudate plus proteins and cells, or cells, whatever cells, neutrophils, lymphocytes, they are also leaking, which normally should not pass. है ना? And yes, because of this infiltrates, this exudate is a very thick kind of a fluid. It will cause, it is potentially can cause blockages into the lymphatics, and therefore there is a localized area of abscess which develops there. Not just, infection does not just spread, or this particular exudate does not just spread very far from that site, because the lymphatics cannot clear exudate with a lot of cells and the fluids and the proteins. So therefore it is also exudate, it is not pit with pressure. Oh, sorry. So let's see Starling's equation. The sum of Starling forces determine the NFP, that is the net filtration pressure across the capillary bed. Starling forces vary slightly in different tissues, but the net filtration pressure in a typical capillary bed is expressed as net filtration pressure. The formula याद रखिए, which is the hydrostatic pressure of the capillaries plus the interstitial hydrostatic pressure, and the minus the pressure of the plasma, that was the, this IF is the interstitial oncotic pressure, प्लाज्मा का हाइड्रोस्टैटिक प्रेशर प्लस इंटरस्टिशियल ऑस्मोटिक प्रेशर माइनस ऑनकोटिक द प्लाज्मा का, नहीं, इंटरस्टिशियल हाइड्रोस्टैटिक प्रेशर पी लिख रहे, प्लाज्मा निकल जाता मुंह से, और ये वाला जो है दिस इज द प्लाज्मा ऑनकोटिक प्रेशर. ठीक है. सो द नेट फिल्ट्रेशन प्रेशर इन नॉर्मल सिचुएशंस इज वेरी लेस, 0.3 mm of Hg. ये फॉर्मूला रटना ही पड़ेगा यार, और कोई ऑप्शन नहीं है इसको समझाने का. So a very small net filtration pressure actually derives filtration across the capillary membrane, and this very small driving pressure is significant because of the highly permeable nature of the capillary membrane, and the net filtration over the entire capillary is very low because, as we have seen, in the arterial end the filtration goes out and the venous end the filtrations come in. So that is already there, we know, at a given point, but दिस प्रेशर कैन चेंज इन वेरियस सिचुएशंस ऑफ द बॉडी, और उसके वजह से दिक्कत हो सकती है. नोट करेंगे ये बात. और we have already seen that Starling process in the glomerular capillary bed will vary markedly. How let's see. ये क्या हो गया? where is the where is the where is the 4 image? So my person has not high output cardiac failure, fine. Diastolic heart failure, Starling forces, edema. Just with edema, और ये खत्म करते हैं अभी. So anyways, we can do this again. I will correct this next time and we will discuss about edema, because ये PPT में कुछ diagrams missing है. So we will correct this and we will discuss edema and the things again. So apart from this, I think we have explained edema quite well. Pathophysiology of edema, we have seen that because there will be some reabsorption of fluid at the venous end, we have seen that, and the capillary of the capillary is typically very less. If it is very less, then there will be a net loss of fluid inside the interstitium, and therefore this constant leakage of fluid inside from the vascular compartment into the interstitium will be the one cause of edema. Then obviously there are lymphatic system present. The primary function of lymphatic system is to take away the excess fluid which is there in the interstitial compartment, and there is no return in this. This will basically try to return the excess fluid which back to the vascular compartment through the thoracic duct, but this capacity can be very well overwhelmed by the significant alterations in the Starling forces and increased permeability. Okay, so there are two methods of edema. One is the dysfunction of lymphatic system, and which is severe edema, and the second issue will be increase in the net filtration pressure. Okay, by any means. So net filtration pressure by Starling equation, वो इन चारों में से कोई भी एक सिचुएशन हो सकती है. The hydrostatic pressure of the capillaries can increase. What will cause hydrostatic pressure of capillaries to increase? This will increase in high blood pressure. This will increase in high volume. This will increase in exercise. In exercise to some extent, kind of high output states, right? What about interstitial hydrostatic pressure? Why would interstitial hydrostatic pressure increase? This will increase if there is a lymphatic blockage, or this will increase if there is a hydrostatic pressure, means pressure inside, fluid accumulation inside the lymph. Yes, lymphatic blockage is one reason. I don't think other reasons are there. Then plasma oncotic pressure. Plasma oncotic pressure will basically pull the fluid, correct? That's why it becomes negative. Plasma oncotic pressure can be because of electrolyte imbalances. These are the most, and hypoalbuminemia, protein, electrolyte, those kind of thing. Interstitial oncotic pressure can also be because of the presence of proteins, electrolytes inside the tissue. So these forces play a big role in determining how much will be the net filtration pressure. So there are two main causes of edema. One is the net filtration pressure and second one is the lymphatic system. Okay. So Starling forces an edema. So what happens in liver disease? In liver disease, there is decreased plasma protein, therefore decreased plasma oncotic pressure, therefore there is edema. In inflammation, there is increased vascularity, there will be increased leakage of proteins into the interstitial fluid, there will be increased oncotic pressure of the interstitial fluid, so therefore there will be exudative edema. In case of the venous obstruction, there will be again back pressure resulting from the capillary congestion. This will increase the capillary hydrostatic pressure and can lead to edema. This is the mechanism of edema in the CVTs or varicose veins or the venous insufficiencies. Then heart failure, back pressure. This is the heart failure. There is again back pressure resulting in venous congestion and increased capillary hydrostatic pressure. This leads to pulmonary edema. Remember, pulmonary edema, and in severe cases, then leg edema, and then right-sided heart failure. Then can be a liver edema, and a lot of things can happen. What about mixed edema? Mixed edema, there is increased glycoproteins inside the interstitial fluid. This basically will increase the oncotic pressure of the interstitial fluid. Therefore, there will be edema. Nephrotic syndrome, the protein is being lost into the through the urine. So reduced plasma protein, again reduced plasma oncotic pressure, and it loses fluids and edema. So this will cause, this particular case, nephrotic syndrome and all will cause anasarca. Heart failure will also cause anasarca if it is very severe, but it will start with pulmonary edema and leg edema because dependent edema is mostly there. Obstructive obstruction of lymphatics like filariasis or a tumor can impair the lymphatic drainage of the interstitium and then lead to edema. So these are the different reasons why you can have edema. I hope I cleared this. Now then next time we will talk about heart failure. If you want me to take a dedicated class on edema, right, and make more detailed slides, then I need you to comment in this comment section. And I want you to come and join me in the next lecture, which is going to be, which will be a discussion on heart failure. I want you to come and join me, and that will be in Unacademy के platform पे. So come at in Unacademy and join me there, because there I am going to be live in the next half an hour, in the next 15-20 minutes, around 5 p.m. 5 p.m. पे we'll be live and we will be discussing about heart failure cases, and that will be free for you. You can come and join for free on Unacademy. You don't have to take a subscription right away or anything. You can just put my code Paramjit and you will get a free entry to the class. तो ये कोड डालिए, फ्री में आके मेरे से वहाँ पे डिस्कस करिए एमसीक्यूज के बारे में, हार्ट फेलियर के बारे में और सीखिए मुझसे. If you think I explain well, then please support. Please share this code and this video and this link with your friends. This will help motivate us to bring out more lovely sessions with you, for you like this. All right. Thank you so much for all your support. Please like and share this video. Good night. Good day. Take care. Bye bye. Okay.